for gestational age babies in non-diabetic mothers.
So I come again to talk about management of large for gestational age in the absence of diabetes. First, about the definition, a large for gestational age fetus is defined as one whose estimated fetal weight or abdominal circumference is above the 90th, according to some definitions, and 95th according to others, centile. So NICE guidance usually talks about a 95th centile. In contrast to this, macrosomic fetus or macrosomic baby is defined as one whose estimated weight or the birth weight is above 4 or 4.5 kilograms, irrespective of the gestational age. So, if you look at some of the studies conducted in low-income countries, including the Cochrane Review and all those studies, so they use a cutoff of 4 kilos instead of 4.5 kilos. Why? Because the phenotypes in the low-income countries, including the Asian population, may be different, either in terms of their height and weight, BMI, their nutritional status, and therefore, if you look at the outcomes, even from the 4 kg onwards, the outcome seems to be getting worse, and therefore, this is a cutoff that is used in low-income countries. If you look at the global prevalence of LGA, it is about 9%, but it is about 1 to 5% in low-income countries. Why are we worried about LGA? We all know the complications. On the mother's side, an LGA fetus means our labor is going to be prolonged, and there is increased risk of assisted vaginal births, higher cesarean section rates. If they end up in vaginal delivery, there are vaginal lacerations, and the most feared complication of uterine rupture in under-resourced settings when there is poor monitoring and untrained personal monitoring. This is a serious complication. And PPH also is in a large uteri due to LGA baby is one of the reasons for severe PPH. From the baby's side, of course, the most feared complication being shoulder dystocia, which leads to several birth injuries, such as brachial plexus injury, fractures, and neonatal asphyxia, respiratory distress, which may be RDS due to early delivery because we do it iatrogenically, or it could be transient tachypnea of newborn if we do a C-section and meconium aspiration syndrome. The newborn fetus has higher risk of hypoglycemia, polycythemia, NICU admissions. And there is also this nuisance of readmissions because these large babies tend to have late hyperbilirubinemia and also lactation failure. And a lot of these large babies are associated with congenital anomalies as well. But the problems do not stop with birth. There is increased morbidity and mortality if the LGA baby is also preterm, and there is increased risk of obesity, insulin resistance, and cardiovascular disease in adulthood. So, can we prevent LGA? So, there are some genetic syndromes that are associated with LGA, such as Beckwith syndrome. Obviously, these have to be diagnosed and managed appropriately, but they are non-modifiable. Maternal diabetes, we just had a talk, an excellent talk by professor, which is an important reason for LGA, but that is not the scope of this talk. So outside of these two reasons, do we have other reasons for having a large baby? Pre-pregnancy obesity and excessive gestational weight gain, they are coming up as one of the common reasons for a large baby in recent times. We are all aware that the obesity is on the rise, and in our culture where people eat for two in pregnancy, excessive gestational weight gain, particularly in the first trimester, before they even come to us and we can intervene in some form, the damage is already done. And we all know that very early exposure to high sugars or early gestational weight gain leads to makes a baby more prone to have LGA. But even if we intervene later on in pregnancy, the results are not going to be that good. Multiparity and advanced maternal age. Advanced maternal age again is on the rise with more and more IVF pregnancies. And these are also the pregnancies where there is very little activity. Most of them are sedentary and they tend to gain a lot of weight, and this is an important contribution to an LGA baby. Post-term pregnancies, like Dr. Uma pointed out, previously most of the guidances used to say induce them late, and there is definitely a rise in the baby's weight when you go beyond 40 or 41 weeks. But a good proportion of LGA babies have no identifiable cause. This is where we are going to get stuck, and it's a tricky situation. So if there is no identifiable cause, sorry. So can we prevent in the last two causes, namely the excessive weight gain and obesity, and in post-term pregnancy? Weight reduction is an important aspect of preconception care. So trying to get her to an optimal level of weight before she goes in to conceive is probably something that we all can address as primary care physicians. Now, we all know that's a very difficult task. First of all, people don't come for preconception care. Even if they come, just by one visit of nutritional advice and giving them a diet chart, they are not going to be able to achieve. This is going to be an ongoing dialogue with her, with good follow-up in order to achieve a weight loss. And we have a standard weight gain recommendations according to their category of weight, whether they are underweight, normal weight, overweight or obese. But I think this scenario is again changing. A weight gain of 7 to even 12 kilos in an overweight individual is not acceptable anymore. More and more papers are looking at whether we should reduce the recommended weight gain or even look at weight loss in very obese women. And more and more we are tending to deliver these babies early. So 39 weeks induction in many of the clinical scenarios that we commonly encounter, and definitely by 40 weeks induction or delivering them at 40 weeks is another strategy to reduce the number of LGA babies that we'll land up with. So when you don't have any risk factors, do we have to routinely screen every baby to look for LGA? I don't think so. So it is not recommended in low-risk population. Also, we have problems when we do scans unnecessarily. Scans do have a margin of error. Most studies have shown that there is an overdiagnosis of 44% in the weight of the baby, particularly if you have the extremes of fetal weight, either too small or too high. And if you go very close to the EDD, the margin of error is high. And we are talking about a margin of error of 10 or even 15%. So if the scan says 4.2 kilos, it could be even 3.8 kilos, or worse, if it is 4 kilo, it could be just a 3.6 kilo baby. And a scan estimation, it requires skill of the operator as well as the clinical judgment of the obstetrician. So the formula that is commonly used to calculate, the Hadlock's formula, has probably the least margin of error. There have been meta-analysis, however, to support that yes, we should calculate the estimated fetal weight and routinely screen, because if we do find an estimated weight of above 90th centile or above 4 kilos, it has a very good sensitivity with a positive likelihood ratio of 6.5 in predicting an LGA baby and its consequences. So how do we screen? Clinically, symphysiofundal height measurement is a very easy, cheap method with all its limitations in a low-risk setting where untrained personnel are monitoring low-risk pregnancies. This is probably a good screening method. Whenever there is a symphysiofundal height which is 2 centimeters above the expected height, it could be a filter to refer them for ultrasound. However, it has its limitations. Symphysiofundal height can be erroneous when there is abdominal obesity, when the higher order pregnancies, and when there are fibroids in pregnancy. So even when we do an ultrasound, how accurate is the prediction? We already spoke about the limitation in very late pregnancy with the error. And it also depends upon what kind of growth charts that we use. So Okay, so this is a typical example of the baby tending to grow high. As you can see, this is a BPD. This is the AC. The baby that starts at the 50th centile now has moved on to the 95th centile. And when we plot them on these charts, basically there are two types of charts, descriptive and prescriptive charts. Descriptive charts illustrate the distribution of birth weight in a population without excluding anybody, at least with very little exclusion. So people who are having multiple comorbidities, high BMI, malnourishment, everything is included in this chart. And prescriptive charts are one where the birth weight distribution is for an optimal healthy population, excluding most of the comorbidities that will influence the birth weight. Why should there be a distinction? In general, prescriptive chart is supposed to be better in picking up abnormalities, because if you use a chart that includes everybody, you're going to normalize or even the abnormal ones, and therefore you will not pick up the abnormal ones, and therefore you may be worse at predicting problems in that population. The Integro 21 chart is an excellent example of a prescriptive chart. Now, apart from other problems, the two feared complications that we have when we have an LGA baby is shoulder dystocia and stillbirth. So, shoulder dystocia, overall, it may be just 1% if the baby weighs less than 4 kilo. The risk increases exponentially when the baby crosses, and it is about 5 to 15% in between 4 and 4.5 kilo. Some studies even report incidence as high as 15 to 25% if the birth weight is above 4.5 kilo. But if you look at all the babies who have had shoulder dystocia, 48% of them actually occur in a birth weight less than 4 kilo. Therefore, be prepared as a whole, and you have to have this the anticipation for shoulder dystocia should be there in all deliveries, and the labor ward should be geared to handle this. The other thing about the birth weight and shoulder dystocia is that infants of diabetic mothers have a 2 to 4-fold increased risk of shoulder dystocia compared with infants of the same birth weight born to non-diabetic mothers, for obvious reasons. So coming to stillbirth, so are LGA babies more prone for stillbirth? Papers have looked at this. So if you see this red line, that is the LGA baby, the risk of stillbirth increases from 37 weeks onwards and rises exponentially after 39 weeks. And studies have also, here if you can see the darkened rounds are all the LGA babies in whom the stillbirth risk actually increases after 35 or 36 weeks. So there are studies looking at whether we should be monitoring them, start initiating fetal surveillance after 36 weeks, whether that would make any difference. As of now, we do not know, but most of the professional bodies have started giving out guidelines about induction of labor. Dr. Uma spoke about it. So LGA baby is one of those where early induction would be probably advised. So our dilemmas when we deal with LGA is, how sure am I about LGA? Should I deliver at 38 weeks or give her expectant management? Am I increasing the risk of C-section by inducing early or by waiting beyond 38 weeks and landing up with a large baby in labor? Can I prevent shoulder dystocia by inducing early? Should I monitor for fetal well-being to prevent stillbirth if the pregnancy goes beyond 36 or 37 weeks. So when we counsel these couples, so first of all, we need to tell them that the accuracy of sonographic estimation of fetal weight has its limitations, and therefore they have to understand that. And when we say a large baby, are we able to predict poor outcome? Are we able to say how many of them are going to have shoulder dystocia? Again, we are not sure. We have to include this in our counseling. And we also have to counsel them about our interventions, either induction or cesarean, because inducing agents come with their own side effects of hyperstimulation, fetal distress, failed induction, and cesarean section complications of cesarean sections, future complications, future obstetric implications will have to be told to them. And also, if we decide to deliver earlier than 39, 38 weeks, we have to discuss the risk of RDS in babies. And therefore, we have to make a collaborative decisions. The most recent Cochrane review of 2023, which looked at papers that compared induction versus expectant management for suspected macrosomia, that they came up with the conclusion that induction reduces shoulder dystocia and fractures with a number needed to treat of 60 without increasing the cesarean section rates. So this has changed the protocol in many centers abroad to induce, if you find LGA, induce them early at 38 to 39 weeks. So when we prepare for labor with suspected LGA or suspected macrosomia, we have to decide when to deliver, probably around 38 to 39 weeks. When we have other factors that are contributing to the LGA other than diabetes, such as high BMI, advanced maternal age, do a cardiac evaluation and anesthetic assessment, and then decide whether we want to induce or do an elective C-section. That will depend upon the estimated weight and the previous history of shoulder dystocia, previous obstetric sphincter injury, previous cesarean and other present obstetric complications. Now, labor management, again, induce them during the daytime when the senior personnel are available. Use epidural analgesia as this labor is likely to be prolonged. So the age-old tradition of using action and alert line, though it cannot be literally followed, definitely it gives us an indication that the labor is tending to get tardy. And when we use oxytocin, do use it very judiciously, because oxytocin is probably one of the complications with oxytocin. If left unsupervised and if it is given for a prolonged time with an LGA baby, is uterine rupture, and this is definitely a preventable complication. And therefore, when we use oxytocin, we have to be sure whether we are using it for inadequate contractions or whether there is an underlying cephalopelvic disproportion. And assessment of fetal head, we had a beautiful talk on intrapartum ultrasound, but do not forget the clinical assessment of the fetal position of the fetal head. And I think this is also something that training obstetrician should get skillful on. There are many ways of assessing the fetal position during the clinical examination, by palpating the fetal ear or by being able to say which is the anterior fontanelle and posterior fontanelle and the position of these fontanelles. Use the intrapartum ultrasound. Definitely it's a useful technique in the labor room. Have a scan in the labor room to assess this. And when there is failure of rotation and arrest of descent, early recourse to cesarean section with a senior input is very, very important. And if you are doing an instrumental delivery, make sure all the criteria for instrumental delivery are fulfilled. And for this, you need to know the position and the station. Here again, intrapartum ultrasound will be very useful. And caput, presence of a large caput can be challenging. At delivery, neonatal team should be present, senior obstetrician should be present, a liberal episiotomy may be necessary, anticipate shoulder dystocia and have routine labor ward drills, prevention of PPH by carbetocin or oxytocin may be necessary, look for vaginal tears and suture them under good light and analgesia, and routinely rule out obstetric sphincter injury. So an algorithmic approach to an LGA fetus, screen if possible with clinical findings or with ultrasound, screen for diabetes and refer appropriately, and explain the limitations in our diagnosis and outcomes to the couple, discuss potential risks of our interventions and what could be the possible outcomes. And expectant management is all right if you can be sure that there are no additional morbidities. It does not increase the C-section rate, but it may increase the risk of shoulder dystocia, which you reduce to some extent by inducing at 38 to 39 weeks. Elective cesarean should be carefully decided if the estimated fetal weight is above 4 kilos, definitely above 4.5 kilos, and discuss the risk. Most importantly, if you have a large baby, you cannot eliminate the risk of brachial plexus injury even during the C-section. This is something that should be discussed with the couple. Thank you very much.